If you have religious OCD and you've ever struggled with implementing ERP, exposure and response prevention therapy, you are going to want to see the following interview with Dr. Michael J. Greenberg. Dr. Greenberg is on the forefront of OCD treatment, and he is specializing in a new form of ERP, which he believes is gentler and more effective in some cases than the traditional ERP. Now, you're going to want to hear all of his caveats and all of his reasonings. We all know that ERP is the gold standard treatment for OCD, as you've probably heard. But Dr. Greenberg is turning that theory on its head and suggesting that maybe things aren't as perfect as we thought they were. Again, if you have religious OCD and you're looking for solutions, you're looking for ways to work through some of your obsessions and compulsions, please stick around for the following interview. Let's hear from Dr. Greenberg. Well, I am so excited to welcome Dr. Michael Greenberg. Thank you, Michael, so much for joining us today. We're going to be learning from you a lot about ERP, exposure and response prevention. I'm really happy to have you here because I am not a psychologist. I am not in any way a medical person. And I have a support group, as I was mentioning to you, for people that have religious OCD. And sometimes we need a little bit of help from somebody like you to help us find the motivation that we need to do treatment. So, Michael, you are not just some random Joe off the street who wants to share opinions about ERP. Just tell us a little bit about yourself and give us a picture of who we're talking to today.
Sure. I am a psychologist. I trained in OCD at Mount Sinai in New York. That's not where I did my PhD, but that's where I did my OCD training. And then after I got my license, I did additional training with Elna Yadin, who is, I think she was like at the University of Pennsylvania, which is where a lot of the research on ERP was done. And I'm also someone who has OCD. And my perspective on OCD and on OCD treatment has largely been an outgrowth of like my own need and what did and didn't work for me. And parallel to that, my patients' needs and what was and was not working for them. So I was initially trained in ERP, obviously, and that's the training I did both at Sinai and also with Elna. But then both through my own experience and also clinical experience, I really confronted the limitations for myself and my patients of what ERP, as it is usually practiced, can do. So what that initially looked like was trying to perfect ERP, trying to fix it, which is very consistent with sort of an obsessive compulsive perspective that we need to, like, if we can just get this thing perfect, then we can solve this problem. In analytics speak, we'd call that an omnipotent fantasy. It's a fantasy that if I'm just perfect, I can achieve control over some outcome that I don't really have control over. So that was my initial sort of project. And that produced rumination-focused ERP a few years ago. And then that was very helpful to me and my patients, but I was still confronting the limitations of what that approach could do, which led me into the analytic world, the psychoanalytic world, which focuses on not just behavior and not just conscious thoughts, but on all of the underlying emotional and relational dynamics that produce symptoms. And so now, since that time, I've been in psychoanalysis for 4.5 years, and I've done a lot of analytic training at the institute here and also with a supervisor. So at this point, I am even though I integrate, I still believe in ERP. I think it's very important, and I still believe in rumination-focused ERP. I integrate that with a psychoanalytic perspective about what is sort of really going on here. What is this person really struggling with that is manifesting as these symptoms, but it's not really limited to these symptoms. And my practice, OCD Associates, is a practice that specializes in integrating rumination-focused ERP with a psychoanalytic perspective to understand the sort of deeper, I don't want to say deeper because that makes it sound like I'm saying it's better, the more emotional and relational perspective on what's going on. Okay, yeah. So that's where I am. I am like CBT and psychoanalytic psychologist, and I specialize in OCD. And I think that's the bio.
Awesome. That's awesome. There's so many things that you said that I want to follow up on. So I'm like typing some notes for myself here. The first thing that you mentioned I thought was interesting, where you set out to try to fix ERP. And, everything that we hear in the OCD community is that ERP is the gold standard for OCD treatment, as if it's like this perfect
Hmm.
approach that
Hmm.
has 100 years of research behind it.
Hmm.
And I'm not a psychologist. I just work with people that are religious and have OCD. And I have lots and lots of people in my support group that have dropped out of ERP or that are treatment resistant in some way. Can you speak to that a little bit, like the
I would,
limitations of
I
ERP?
would, I would love to speak to that. So I think what's so interesting about this topic is that it's sort of an obsessive compulsive dynamic that manifests among patients with OCD, but also the community of therapists who treat OCD and informs how we think about the treatment for OCD. So it's sort of very cyclical and meta. But with that aside, basically, the two concepts that I would think about here are splitting, which means seeing things as either ideal or totally garbage, and omnipotent fantasy, which is again this fantasy that if only I'm good enough, so the two are connected, if only I'm good enough, that I can achieve control over this thing that I really don't have control over. Okay. And even though omnipotency can present as grandiosity, like I'm going to fix ERP, it's born out of a sense of helplessness. Like I don't have any other choice but to believe that I can do this for myself because otherwise I'm totally helpless in this problem. So I think that the OCD community, and I say community to include both patients and therapists, the OCD community's perspective on ERP is split. It is idealized and other treatments are devalued. In reality, and I think I love that you use the term gold standard because I think that's a perfect example of how this works. What does gold standard mean? Well, technically, it's totally correct. This is our best treatment that we have. It is the gold standard, meaning it's the best treatment that we have or the best research treatment that we have. But that's not the same thing as saying that it's a perfect treatment or that it can help everyone. And in fact, there was a pretty, I don't know if damning is the right word. There was a negative, no, it's not even, there was a meta-analysis that came out, I don't know, 2 or so years ago. Maybe I don't have a good sense of chronology. A couple years ago, a meta-analysis came out and it showed that ERP is not nearly as like perfect as we thought it was. Now, people who have OCD who split, again, present company included, will hear this and say, oh, so ERP is bad. And that is not what we're saying because that's splitting. We're saying ERP is very helpful, but it is not ideal. It is not a totally effective treatment for anyone, I would argue. And it is also not an effective treatment for everyone. So not only is it not going to help anyone all the way, it's also not going to help a lot of people. And the research that we have on it is, again, that it's very helpful to many people. So that means it's a good treatment, but it's not the be all end all, and it's not ideal. And language like gold standard is on paper technically true, but it sort of colludes with this split perspective that wants to see ERP as not just a good treatment, but as the ideal treatment, the perfect treatment, which leads again, if you're idealizing one thing, you're devaluing another. So ERP is idealized, and then other approaches are devalued. And so you have this situation where people are doing this treatment that's not really giving them everything they need potentially, but then they're not allowed by themselves or others to go pursue other adjunctive treatments. Some people do, but many people don't because those are bad. Does that make sense? And I think that I lost my train of thought. But anyway, point being, I think that this splitting is present in the community. And again, I'm not saying that I'm above it. I think historically I was doing exactly the same thing. And again, I've been in analysis for 4.5 years. It's not to talk about how perfect I am. It's to work through these same dynamics in myself. So I'm not separating myself from people who tend to do this, but I think it's important for the community to reflect on this. It's also a good example of how a behavioral perspective cannot really address all of the deeper issues. And so even if you change somebody's behavior in terms of their OCD symptoms, you're not really addressing these more personality-based problems, such as splitting, such as omnipotency, such as struggling with helplessness and dependency. So these are sort of issues that are not even named. They're not even sort of identified in a behavioral treatment. Yeah. And again, I'm also not idealizing psychoanalytic treatment. We have a long history of people, even in the analytic world, owning that it's not always an effective treatment or often not an effective treatment for at least physical behavioral compulsions. So in my opinion, we need to sort of tone down the splitting and think more realistically about things that are helpful in different ways. So I think ERP is a good, helpful treatment. And I think a psychoanalytic perspective adds a lot that ERP doesn't have.
Yeah, thank you so much for that. I think when you started talking about how this idealized form of treatment, how ERP is not the end all treatment, I'm sure some of our watchers were bringing the confetti out because as, you know, as
Yeah,
idealized as
yeah.
ERP is, most of us hate doing it for ourselves. It's just a
Oh, yeah. Well, can
very, yeah, go ahead.
sorry, I'm totally interrupting. I remembered what I wanted to say before. I apologize for interrupting. It's a bad habit. What I wanted to say before is that another way that you see this is that when ERP isn't working, either from a patient or for a therapist, the attitude is usually, or the approach is usually to figure out what we're doing wrong. Like the therapist is like, ERP is not working or they're not getting all the way better. I must be doing it wrong. Let me consult, let me ask a group, let me whatever. Or the patients are like, I must be doing ERP wrong if I'm not all the way better. And that sort of reveals this fantasy that if only we got this exactly right, people would get all the way better. When in reality, again, that's not real and that's not the research, but that is how we relate to it. Now, of course, there is room for getting ERP better. In other words, sometimes it's good to consult. Sometimes a patient really could get better if you were doing it better. But it doesn't mean that that's always the case. And it doesn't mean automatically that if it's not working, it's somebody's fault. It might just be that this is a limited treatment. Yeah. So I give credit to the people who are like, not only is this not working for me, but that's not my fault. Like, this is just not for me. People who are not idealizing the treatment, who are saying there's something here that's not what I need, is going to be the case for some people, or maybe for many people in different ways.
Yeah, yeah. So you are arguing for more of a systems approach where there are possibly multiple streams converging in a person that could be causing the issue and trying to deal with multiple aspects instead of just one single approach. Am I getting that right?
So I think you're talking both about cause like etiology, like what's causing the problem, and then you're also talking about treatment in terms of approach to treatment. So I'm arguing that what is leading to it is multifaceted, but includes a lot of that. A huge factor in OCD is emotional and relational factors. So a
Mm-hmm.
lot of people, I need to cough. In terms of what's causing it, I want to be clear, like we know that OCD has, biological components. We know there's a heritability factor. So it's not one thing. And a psychoanalytic approach sort of emphasizes this idea of multi-determinism, which means that it's not one thing. It's never one thing. People who are obsessive compulsive, again, present company included, we want it to be simple. We want it to be, this is causing that. Now we know everything we need to know and we can solve it. So we want, it's the sister of omnipotence is omniscience. We know exactly what's going on here. It's simple. We know the whole thing and we totally know what to do about it. In reality, it's more than one thing. It's multifaceted. It's complicated, unfortunately. It's not a quick fix. And from an analytic perspective, there are all sorts of emotional and relational factors that are producing these symptoms. Just for example, a lot of people, those come from backgrounds where there was some threat to attachment, where there were either, and a threat to attachment, anybody who's read anything I've written, this is something they know already, but just this one example, it could have been a threat to attachment, like there was a parent who was sick or was going to die or did die. There's some sensitization to the prospect of loss. Or it could have looked like, let's say, a borderline parent who, if they got upset, they were like the love was gone. They split in a different way. And like that was like you could be dropped at any moment emotionally. So if you look at the histories of people with OCD, we often see dynamics like this. And we often see conflicts around different types of healthy aggression. And we often see whatever. I won't go into detail, but the point is there are these underlying factors that are producing these symptoms. Now, so that's in terms of etiology. In terms of treatment, there doesn't have to be one way to help a person. But I think that in my opinion, we absolutely know that you can help a person tremendously with OCD by changing behavior and by challenging certain thoughts, meaning working on a cognitive behavioral level. That is absolutely helpful. But you can also help people by working on an emotional level, by working on a relational level. And that's what we would call a dynamic approach or a psychoanalytic approach. I'm not sure I'm not sure what you meant by systems. It's not a word that I use. I'm not saying it's wrong, but I think it might, for some people, evoke family systems, which I don't practice. So I would think in terms of we as people, we have conscious thoughts, we have behaviors, and we have unconscious emotions and emotional conflicts. And there's no reason why we can't work on all of those levels. They're not mutually exclusive. All of us have a conscious thought process. All of us have behaviors that we can change. And all of us also have a vast, infinitely vast unconscious of all the thoughts and feelings related to all the things that we've experienced in our entire life.
Yeah. Yeah. Thank you for that. I think we are talking about the same thing. I'm coming from a different field. My doctorate is in a religious area. All my degrees are in religious areas. And that's some terminology that we use when we try to express basically what you're saying, that there's not one single cause, and we may not know omnisciently what that single cause is for any phenomenon that we're experiencing.
Okay, so then I'm down with
But
that.
just trying to look at the broader perspective. Yeah, I really like how you explain that. And in fact, I want to get to your rumination focused ERP in just a moment, but if it's okay with you, I want to take a detour into the psychoanalytic realm. Again, I'm not an expert in this field at all, but my own experience with OCD, I had such an interesting way of finding out that I had OCD because I had no clue that the obsessions and compulsions I was experiencing in my early 20s and teens was obsessive compulsive. But I was working with a therapist who was doing CBT with me. And she was just gushing about the effectiveness of CBT for some of the issues I was dealing with. And she said, Jamie, I do CBT with everybody, except people that have OCD, because it can really backfire on them. And she gave me all kinds of CBT homework where I was supposed to argue with my thoughts and, this kind of thing. And guess what? It really was backfiring. And I was spending 23 hours a day arguing with my thoughts. And her little comment came back to me that she said that for people with OCD, it can backfire. That was the first time I Googled OCD symptoms.
Oh, meaning she already knew you had OCD.
She did not know I had OCD. She completely missed it.
She was just saying that off the cuff.
Off the cuff. And she was working with me on my depression and other things that I was dealing with and trying to convince me like, yeah, CBT is going to be great for you. And I found that this arguing with myself wasn't going well. So I wonder, but at the same time, I do want to say that a lot of the people that are in my support group and people that I've worked with, they're dealing with OCD, but they're also, many of them, I can't say all because I haven't done, studies that can give you statistics on this, but many of them are dealing with shame, dealing with, as you mentioned, family dynamics that obviously have impacted them in very negative ways. So can you speak to that sort of tension with the CBT and psychoanalytic realm, how it can benefit a person with this complex dimensions that they're dealing with the OCD without turning into a case for them to just argue with themselves and argue with their thoughts?
Okay, so let's zoom in just on that particular piece for a second. So CBT is a broad umbrella term, and it's not one thing, and it just means any treatment that's intervening on the level of conscious thoughts and behaviors. If we're challenging thoughts, if we're stopping thoughts, if we're changing behavior, if any intervention that has to do, even if we're doing progressive relaxation, like deep breathing, anything that has to do with behavior and cognition falls under CBT. Okay, we're intervening on that level. There are different CBTs for different psychopathologies, which I've heard is a triggering word for some people. It just means like mental health issues. Okay, so I don't know what if somebody was like, I thought that means like schizophrenia. I'm like, no, it just means everything. So there are different CBT approaches for different psychopathologies. Like for depression, it might be behavioral activation or challenging thoughts or cognitive distortions. For there are various CBT interventions for trauma, like prolonged exposure or CPT, and the CBT for OCD is ERP. Okay, so this person was saying that CBT doesn't work for OCD, but really she was not doing the specific type of CBT that we use for ERP. So meaning anybody, rumination focused, no matter who you are treating OCD, nobody is having you just that's not actually true. Most people, anybody competent is not having you argue with your thoughts. I think the vast majority of people who treat OCD know that that's not helpful. And so that person was saying that the way that she practices CBT, which again, most people who treat OCD would say, of course, that's inappropriate and ineffective for OCD. That doesn't work for OCD, but it doesn't mean that CBT doesn't work for OCD. It means that I think maybe I've gotten convoluted. She was broadly speaking practicing CBT, but she wasn't doing the specific version that works for OCD.
Right.
Okay. So I don't think that your experience with her should take points as a point against what am I looking for? I don't think it should detract from ERP's effectiveness, because what she was doing was not the right thing to be doing for OCD. Okay. So fine. Yeah. But then even if you are doing the CBT that is appropriate for OCD, namely ERP, right? I'm saying that even that is helpful, can be tremendously helpful. And let nobody think that I'm saying, oh, ERP is like not great. ERP can save people's lives. It absolutely does. It changes lives. It gets people's one analogy that I use frequently is it's like it's like a diet, changing somebody's behavior around what they eat, teaching them how to eat healthy, that can be life-saving and life-changing, to get somebody to eat healthy. But it won't address deeper issues around their relationship to food and with their relationship to eating and why they're eating or binging or not eating at various different times. So I think that's a good analogy. I have, again, gone too far afield. Coming back, from a psychoanalytic perspective, it's all connected. There is no line between your OCD symptom and your shame and your family issues. They're not just connected, they're all part of the same person. So it's sort of like when we think of personality, we would never think about splitting off one part of a person's personality and imagining that it was totally disconnected from the rest. Psychopathology is also personality based. It's part of who you are. It's part of like how you see it's all connected. And at least from a psychoanalytic perspective, okay? And a CBT therapist might say, no, it's not a personality disorder, it's an anxiety disorder, it's different. So that's not how I view things. From a psychoanalytic perspective, these things are all connected. And of course, people with OCD have complex, often challenging family dynamics in their family of origin. That's part and parcel of their OCD. That's a part of why they have OCD. I said a part of why they have OCD, a part of how their OCD manifests. So like it goes without saying from a psychoanalytic perspective that these people have all of these problems all together. Yeah.
Yeah, that makes sense. Thank you for that. With that, I know that I could ask you a lot more about the psychoanalytic perspective, but I really wanted to ask about your form of ERP that I think it's unique to you and you've come up with it, rumination focused ERP. I'm really interested in this because my role from the religious perspective is that I'm meeting with people that have religious OCD and they come to me and they say, Jamie, I went to therapy, it didn't work, I didn't like it. I felt like my therapist was pushing me into sin by asking me to do these different exposures. And they come away from therapy feeling an immense amount of guilt and wondering if God is mad at them for having tried to get better. And often the ERP leaves a really bad taste in their mouth. And my role is to encourage people to go to therapy. I don't do therapy, but I'm able to tell them, hey, I think what you're dealing with, that doesn't sound like the way God works. I think you might be dealing with something else. Why don't you go talk to somebody who's an expert in these kinds of things? So I like to refer them and tell them, please go see a therapist. And they say, no, I don't want to do ERP. And you've come up with an adjustment to the traditional ERP approach that may be a little gentler. We were emailing a little bit and you said that you felt as though rumination focused ERP can work very well for religious OCD. And I would just love to hear your thoughts on that. What is rumination focused ERP? How does it differ from traditional ERP? And how would that look like in the scrupulosity context?
Yeah, okay. So basically, this is a pretty simple answer. So, okay. Basically, traditional ERP is based on the concept of habituation, which means that you are avoiding something that makes you anxious, and therefore you're never habituating to it. And if you would confront the thing that makes you anxious and feel your anxiety would eventually go down. You would stop feeling anxious. Okay. Does that concept make sense?
Yes.
Okay. And I used to practice this way. I was trained this way. Everybody was trained this way. Not everybody. Nowadays, maybe we have some inhibitory learning people, but back in the day, everybody was trained this way. And it's a very simple pitch. It's like, well, if you're afraid of the dog, then you cross the street when there's a dog, and then you never get used to being around the dog. And so what we need to do is we need to put you in contact with the dog so you can get used to being with the dog and grow less anxious. Okay. Okay. So basically, my understanding of this concept is that it doesn't actually apply to anxiety. I think that habituation applies to fear. And I think a fear, that we feel in our bodies, we know what being scared feels like. And I think that it's important to distinguish fear from anxiety, from our experience of anxiety, which is, spiraling mentally. And I think that you cannot habituate to anxiety. I think that anxiety is okay, but let me pause 1 second, okay? When I'm talking about anxiety here, because you could talk about anxiety and mean something else. You could mean any experience of emotional conflict in your body, your stomach hurts, you're shaking, that's anxiety. I'm not talking about that. I'm talking about what people with OCD or anxiety disorders know as the experience of anxiety, which is what's going on up here, and like that, the sort of panicked spiraling, that anxiety. So what I think that that experience of anxiety is the consequence of rumination, meaning it is literally you sitting there trying to figure something out, trying to solve some problem. And as long as you're doing that, the feeling of anxiety does not go away. As long as you're doing that, you perpetuate the anxiety. And so the reason, in my opinion, that habituation, that traditional exposure doesn't work is because, not that it doesn't work, that
It's limited.
no, I want to say this. I want to talk about the mechanism of, you're right, but I want to say it very clearly in terms of the mechanism of action. If you assume that anxiety is the consequence of ruminating, then as long as you're ruminating, you're going to feel anxious, and habituation doesn't make a difference. So for example, if somebody has a stomach ache because they're eating something that makes their stomach hurt, you wouldn't say, let's make your stomach hurt more so that you can habituate to that feeling, right? That wouldn't make sense. We'd say you have to stop doing the thing that's making your stomach hurt in the first place. And as long as you keep doing that thing, it's still going to hurt, right? So from this perspective, anxiety is the consequence of a behavior, namely ruminating or trying to figure something out, analyzing, and therefore habituation is irrelevant. Okay, that's sort of the starting point. Then the question was, okay, if you get rid of the concept of habituation, what does ERP look like if you get rid of that? Because we know ERP works to some degree, to a large degree, to a significant degree, let's say that. So what does it look like if you sanitize it of this idea of habituation? Now, notably, there have been approaches that have sort of included other pieces like inhibitory learning. They've said, well, maybe it's also about learning, but inhibitory learning never sanitized it of habituation. They said, what about focusing on inhibitory learning? It didn't say, what if it's only about learning? And what if we get rid of habituation? What would this look like? Does that make sense? So my question was, if you really discard this idea of habituation, what does this look like? And what ended up being the sort of outgrowth of this thought process was it actually totally flips exposure on its head, because rather than wanting to maximize anxiety during an exposure because we want somebody to feel the anxiety so they can habituate to it, if you take habituation out of the picture and instead you're thinking about rumination as causing anxiety, then in fact, during an exposure, you would want somebody to not be ruminating and to not be feeling anxiety, right? And so instead of trying to do something to make somebody anxious, you're trying to do something while they're not anxious. Does that make sense? This is not the clearest that I've ever explained this. There's a better version on the website. If anybody wants a better, more articulate version of this, go to my website and read the articles about rumination-focused ERP. This is not my best version today. Okay, fine. With that being said, the idea of doing extreme exposures only makes sense if you are trying to make somebody anxious for the purpose of habituation, right?
Right.
Okay. The rumination-focused ERP approach is not concerned with habituation. And so the question becomes, how do we restore a person's sense of agency? It's, instead of thinking about how do we get this person to habituate to anxiety, we say, here is a person who feels as if they don't have control over something because they're so scared. Let's show them that they indeed do have control and that they can do it despite feeling scared, and that they can manage their experience of anxiety by refraining from rumination. Okay, again, this is not my best version. I encourage anybody who wants the best version.
It makes sense. Can you give us an example of what this would look like in a religious OCD context? Let's say we've got somebody who they're so afraid that they're going to go to hell. They're afraid to touch the Bible. They're afraid to pray, because if they do that, then they're just flooded with compulsive ritualizations that they need to do. What would this look like in a case like that?
Okay, so first of all, we'd be asking a person, there are two pieces. Number one question would be, how much of this is driven by the fact that you don't know how to stop ruminating? So if you're afraid to do something because then you'll be confronted by an onslaught of rumination, then if we can show you that you can actually control that, maybe this thing won't be scary at all because you can control that experience afterwards. So there are a lot of things that people don't want to do because then they'll be anxious afterwards. And if we can show them actually you can rein that in, then this thing is no longer scary. Okay, so that's one piece. Another piece is a person is scared to do something, but that doesn't necessarily mean that they actually think it's a problem. And so one of the big questions we're asking in rumination-focused ERP is, what do you actually want? Where is the line for you? So rather than the therapist saying, well, we need to do the most extreme thing in order to habituate to something, and so I will determine what that is, rumination-focused ERP is totally patient-driven in terms of determining where the line is between what I want to do and what I don't want to do. So our focus is on restoring the patient's sense of agency. And so the patient would say, for example, I do actually think my religious belief is actually that I am not allowed to do X. However, my religious belief is not really that I'm not allowed to do Y. I just get scared that maybe what if, whatever. But what do you actually want? What do you actually endorse? What would you actually endorse for somebody else? It's just X. Okay, fine. So then you've determined where the line is, and we're only going to do exposure up until that line. We could have a conversation about that line. We could have a conversation about whether that's really true or where you got that or why you think that or whether that's working for you. Fine. But at the end of the day, that's just exploratory, and it's the patient who gets to decide where the line is. And so you would never be, in our approach, you would never be doing something that you don't want to do. You might be doing something that's scary for you, but it would be something that's scary for you that you want to do. You believe in doing that. And so I think that piece is especially relevant to people's scrupulosity. But
Yeah.
honestly, it's relevant to a lot of people with OCD, right? Because people with OCD are very often have dynamics around control and being told what to do from childhood. And a lot of times I think ERP can collude with those dynamics and sort of just land right on top of them. If you want to get better or if you want to stay in therapy with me, you have to do what I say can land on top of parental dynamics. And so this can also be a corrective experience in which we're saying, this is not, I'm not imposing anything on you. I want to help you to formulate what it is that you want, where your personal boundaries are, what feels comfortable for you. And then I want to support you in doing what you've determined is right for you.
Yeah, thank you so much for that emphasis on restoring agency. I actually have a lot of people that come to me in a panic, and I'm sort of somehow like a religious authority for them. And they say, look, my therapist gave me this list of 10 things. I'm supposed to do them. I'm only comfortable with 2 of them. They told me I'm going home and I'm not able to stay in this treatment center unless I commit to doing these 10 things. But I think these are sin. And they're kind of freaking out because, as you mentioned, they don't feel that they have a sense of agency. And that's obviously very disruptive, I think, to the recovery process. Now, when you talk about stopping rumination, I love the idea of that. I think that's, I want to know how that happens.
Okay.
How is it not the snap the rubber band on your wrist and stop ruminating?
It's totally different. Okay. The starting point for the whole thing is realizing that rumination is analytical thinking. Okay. So there's a difference between a thought occurring to you or knowing something versus trying to figure something out. So for example, I'll use a sexual orientation OCD as an example because I don't know, I think it's an easy example and a pretty common one. People used to think that they used to talk about OCD in terms of intrusive thoughts. And they would talk about HOCD, for example, or sexual orientation OCD, that here is a person who's spending all day going, you're gay, you're gay, you're gay, you're gay, like whatever. Or what if you're gay? What if you're gay? And in reality, that's not the subjective experience of somebody with HOCD. The subjective experience is trying to figure out if you're gay. Same thing for pedophilia OCD. It's trying to figure out if you're a pedophile, trying to figure out if you're in the right relationship, trying to figure out if you have the right beliefs, trying to figure out if XYZ is true or not, trying to figure out whether you did something wrong, if you hit somebody with your car, etc. It's not just, I hit somebody with my car. I hit somebody with my car. It's not just an intrusive thought. It's an analytical thought process. It's trying to figure out the answer to that. The reason that that is so crucial is because analytical thinking is controllable. You can stop doing it. It is something you're actually doing on purpose, not on purpose. People object to my language around this. You're not doing it on purpose in the sense that you don't want to be doing it, but it's controllable is maybe the best way to say this. It is something you can stop doing. You may be conflicted about stopping it. You may feel like it's important to do it or like something bad might happen if you don't. But functionally, like physically, it's not physical because it's cognitive, but you can stop. Just like if you were doing a math problem, you could choose not to do the math problem. If somebody was holding a gun to your head and saying, solve the math problem or I'll kill you, it would be hard to make the decision to stop the math problem. But technically, on a cognitive level, you could stop solving the math problem. It doesn't just solve itself, right? Okay. So once you recognize that it's analytical thinking, all of a sudden it means that you can stop. The question might not go away. The math problem is still there, but you can choose to refrain from trying to solve it. And that is what it means to not ruminate. There are some finer points where people get stuck. Those are covered in the article on the website called How to Stop Ruminating. So I won't go into them here, but that's sort of the crux of it. So thought, like, it's not a rubber band because we're not trying to make, it's not thought suppression. We're not pushing a thought away. We're not saying, I don't want that thought to occur to me. No, we're saying that thought can occur to me. That thought can be right here. Just like the math problem can be on the whiteboard. And it doesn't mean that I have to solve it or engage with it. Does that make sense?
It does, 100%.
Thought suppression is trying to somehow make the math problem go away. Not ruminating means the math problem is there, the question is there, the thing that's scary is there. I'm making a decision to not engage in trying to figure that out right now. I'm not engaging analytical thinking.
Yeah, perfect. Now, how would intrusive thoughts fit into this discussion? Would you consider those as something that you have volition over or not?
Okay, good question. So intrusive thoughts that term is used to describe various different phenomena that are not all the same thing. So the majority of cases of people who say they're having intrusive thoughts are not really having intrusive thoughts. They're really preoccupied with a question that terrifies them. Okay, so the majority of people, I would say in the 90% of people who are saying I'm having intrusive thoughts about pick a thing, I mean, whatever, about being a pedophile, they're not having intrusive thoughts. It's not having like flashes of something. It's that they're literally spending all day, every day, from the moment they wake up until the moment they go to sleep, and sometimes even in their dreams, trying to answer this question. That's not intrusive thoughts. That's you ruminating all the time. Does that make sense as a difference?
It does. I think a lot of the people in my community might scratch their heads at that. So let me just press the point a little bit if
Yeah.
that's okay.
Let me add one piece,
But
one
please,
other
yeah.
piece. There are people though who have intrusive thoughts where it's just the presence of the thought itself is what they're fighting, right? Like that thing is there and they can't make it go away. And that's a very different presentation. Those people do exist and we treat that a little differently. There, the key is differentiating between awareness and attention and letting it be there without directing attention towards it. So those people I might describe more accurately as having intrusive thoughts. Anybody who's trying to push it out of their mind, trying to make the math problem go away, they will struggle with intrusive thoughts of it coming back. But that is not the majority of cases when people present saying they're having intrusive thoughts. Usually they're just using language that they've heard to inaccurately describe something they're experiencing. But with that being said, what was your...
How would you classify, and of course, I don't know the proper terminology for these things, but a lot of the people in the religious OCD community, at least in my corner of it, blasphemous thoughts is a really big struggle where they're just going along their day and then they, maybe hear the name of God on a movie or they see it on a billboard and they get, obviously.
Okay, good question. So So there we're talking about a thought occurring to someone. Okay, not that might be followed by trying to figure out if they believed it, trying to figure out why they had that thought, so it might be followed by rumination, but you're saying sometimes just the thought occurring to them is a problem for them. For those people, I would say the only way they are going to be okay is coming to terms with the fact that you cannot control what thoughts occur to you. Okay. And if you are trying to control your feelings or trying to control what thoughts occur to you, that's a recipe for psychopathology. That's a recipe for OCD specifically. So many people with OCD, going back to splitting, are striving to be ideal, not only in their behavior, but in their internal life. They don't want to have any feeling that's not acceptable. They don't want to have any thought that's not acceptable. That is not human and not real. That's not real. That is not a realistic goal. It's not a healthy goal. That is not what nobody has control over their thoughts and feelings. And now I say thoughts, but rumination is different, right? Thoughts versus thinking, if you want. Mm-hmm. Nobody has control over what thoughts occur to them. Nobody has control over something being present in their mind. Not paying attention, ruminating, but what thoughts occur to them, their feelings, etc. Trying to control that is totally doomed to fail. And not only is it not possible, you will actually make yourself very sick. And I'm also pretty sure that no religion actually prescribes that. So what we have here is somebody who is taking their own dynamics that are probably based on family of origin issues around splitting and trying to be ideal and being scared to have certain aggressive or sexual feelings because whatever, the whole story of the family. And then they're bringing that to religion and then imagining that that is coming from religion, but it's not. Does that make sense? I'm pretty sure there's no religion that says that a thought occurring to you is a problem, because that would be impossible because that's human, right?
Right.
So we have people who are imposing their own psychodynamics and around perfectionism and trying to be ideal and trying to not have unacceptable thoughts and feelings. They're bringing that to their religious practice. But it's not, I think, I mean, correct me if I'm wrong, I don't think that's coming from the religion itself.
No, no, no. I would totally agree with you on that. So if I was to summarize, tell me if I'm understanding you correctly. So in the case of a genuine intrusive thought or some uncontrolled,
Or in other words, in the case of thoughts that occur to you that feel unacceptable to you.
yeah, exactly.
Right.
Such as a religious blasphemous thought that was unwanted. Are you saying there's like kind of two steps? The first step is to recognize and accept the fact that thoughts just come. And then the
Yeah.
second part would be don't ruminate about why you
Correct. Don't engage. Right. So we need to accept the thoughts occur to us, and then we need to not ruminate about it. Now, right now, we're talking only in cognitive behavioral terms,
Mhm.
right? But there's also like underlying emotional stuff here again around trying to be perfect in terms of your thoughts, in terms of what I'll give you one example. Give me an example of a blasphemous thought. Like what
Okay.
if
Well, a lot of people will get just like bad curse words against the name of God, for example.
Okay, so in other words, they have aggressive thoughts towards God.
Yeah.
Okay. So, I mean, you're not an analyst, but let's take a shot at interpreting what that might be about in a family of origin. So right now, a person is having aggressive thoughts about God, and that scares them. You know, where do you think this might come from for this person? It's unacceptable to have aggressive thoughts towards God. Probably it was unacceptable to have aggressive thoughts towards mom or dad, right? Because no matter what you believe about God, you haven't met them, right? So it's clearly your own dynamics that you're bringing to that relationship, right? And that's not weighing in on true, not true. That's just saying no matter what you believe, like you are bringing your own projections to your relationship with God and your own dynamics and your own expectations about parents and your own expectations about if I do something wrong, I'm going to be totally disowned. And yet somebody else in your religion thinks that God forgives them and God loves them no matter what. Well, this is the same God, but these people grew up in different families and are bringing different dynamics and different projections and different expectations to a parental relationship, right? So this person feels like it's unacceptable to have aggressive feelings towards someone, or they will be punished, or they will be bad, or they will be whatever. You can't just address this in terms of cognitive behavioral. So yes, on a cognitive behavioral level, you need to not let that thought occur to you and then don't engage. Don't try to control that thought occurring to you. Don't try to control the thought occurring to you, but do control analyzing it or directing attention towards it. But then we got to go deeper because this is not really just about this intrusive thought. And by the way, the person who's scared of having intrusive thoughts of curses towards God probably also struggles with aggression in their current relationship with their partner, right? This is not about religion and it's not about God.
Yeah, that's super interesting that you say that. I'm remembering one person that I talked to who had these aggressive thoughts towards God, and boy, it was just so unacceptable, as you've said, and causing lots and lots of anxiety. I asked him, I said, "Have you talked to God about this? Have you prayed and just like open your heart and told God, like, God, this is what I'm feeling right now. This is what I'm thinking. These are the thoughts about you that I'm getting." And he said, "Oh, no, no, I could never do that. I could never tell God what I'm thinking." And it's exactly like you're saying, it's that unacceptable that I
Yeah.
can't actually be open about the aggression that I'm feeling.
And I guarantee you 100% that that can be traced to their family of origin. For one reason or another, it was really scary to have aggressive thoughts or critical thought, whatever it might be, whatever the version of healthy aggressive that's manifesting here, that was also unacceptable growing up. Unacceptable doesn't necessarily mean you were punished. Maybe it means that you had a parent who was really sick, and to burden them with your aggression was terrifying because you were afraid they would not be able to handle it or die. Or maybe you had a fantasy that your aggressive thoughts were the reason your parents got divorced. Like who knows what it was, but there was some reason that it was not. There was some reason. This person who is afraid to have aggressive thoughts towards God, it did not start with God.
That statement totally needs to be highlighted. I love that. It did not start with God. We're almost out of time. I could keep you on this call for a long time and just pick your brain on different things. But if I could just ask maybe one more thing.
Sure.
For those who watch this on YouTube, what is your recommendation for how somebody that has religious OCD, how can we move forward? If you could just speak to the people among us who have tried traditional ERP or traditional approaches and they don't feel like it's worked for them, what would you recommend for them to do?
Okay, a couple of things. Number one is there are therapists who practice traditional ERP but are respectful of people's I think I should have said this first. There are people who practice traditional ERP, not rumination focused ERP, but consult with clergy and are respectful of people's religious boundaries. That 100% exists. So we shouldn't say that you cannot practice traditional ERP and also be respectful of people's religious beliefs. Absolutely, you can. I know many people who do that.
Right.
Okay. So potentially one option is to find just a respectful, I guess they would call them culturally competent therapist. Okay. Then if you wanted to find a rumination focused ERP therapist, you could email our practice. If we don't have availability or don't see people where you're located, we've had over 100 therapists go through the training, and we can make a referral to people who practice this way in other places. They're not like thoroughly trained by us. We don't take responsibility. They've only done like an 8-week training, but at least if you're looking for someone who potentially practices from a rumination focused perspective, they exist outside of our practice as well. And then if you're someone who's like, I don't want to do ERP, I don't want to do that, I don't want to work this way, that's fine. The point is there are other treatment options available to you. And by all means, go find somebody who's psychoanalytic or a psychoanalyst. And I should say, you can do a psychoanalytic therapy that's not psychoanalysis. I'm in psychoanalysis, which means used to be 4, now it's 5 times a week on the couch. I say 99% of the words that are said. That's psychoanalysis. It's been profoundly impactful. I'm a huge fan. I'm very grateful for it. Okay, so I'm not knocking it. I am infinitely grateful for it. But there are people who don't want to do that. You can have a psychoanalytic therapy that's just, it's a talk therapy, meaning you're talking to someone, but that person is thinking along the lines that we're talking about, right? That person is helping you to see how this is not really about God, helping you to resolve some of your conflicts around, let's say, aggression, trauma that happened, fears that you had as a child, sort of deflating the symptom by addressing the emotional dynamics that are contributing to it. So it's sort of taking the charge out of the symptoms by addressing the underlying emotional factors. So you can do a psychoanalytic treatment like that or a psychodynamic treatment like that. That's not psychoanalysis 5 times a week on the couch per se. So in that case, what you would do is you would call your local psychoanalytic institute, which exists in most places, and you would ask them for a referral. You could tell them, specifically what your problem is, and hopefully they have somebody in the institute or affiliated with the institute who has experience with that, and hopefully they can make a referral.
Yeah. Okay. That sounds awesome. I am going to put in the description below this video, when I upload it, I'm going to put your information, your website, how people can get in touch with you through that. Thank you very much for your advice today. Thank you for sharing about this. I just want to highlight that I think this conversation is so helpful because it's opening up other options for OCD treatment, other approaches that we just don't hear about very often. And so I know that those on my blog and my channel are going to be so grateful for you just taking the time to share with us today. And so yeah, thank you very much, Michael. We appreciate having you here today.
Thank you for having me. It was a pleasure. Nice to meet you.
Thank you.